Good afternoon, dear friends. Thank you for your attention for my YouTube channel. Thank you for your question and for your ideas, and it helped for me generate new ideas, and already I have written program for pharmacists and for medical doctors concerning on pharmacovigilance and drug safety topics, and I hope this program together with medical university will be improving, and it will help for medical doctors to get a new knowledge. It's two approaches. One approach is for medical doctors who conduct medical activities as a medical doctors, healthcare professional and pharmacist. Another one it's a way for medical doctors and pharmacists who would like to get new specialization. It's a pharmacovigilance specialist, and this program includes more regulatory aspects of pharmacovigilance, GVP questions, very important for a specialist of pharmacovigilance field. For our new participants, I would like to introduce myself. My name is Galina Cordero. I am qualified personality of pharmacovigilance, head of pharmacovigilance department, clinical expert, GCK Pharmac. Today we will talk about drug-induced pancreatitis because what I saw in my practical life, in my professional life, that interesting things that, for example, diabetes mellitus has signs of pancreatitis, and for example, patients with pancreatitis can have diabetes mellitus, and this group of patients have administered diabetic, for example, like drugs for treatment diabetes mellitus. It's like metformin, it's like, for example, diabeton. And interesting thing that this group of drugs, treatment of this group of drugs, can cause approximately pancreatitis, and you should remember it, and all time be aware of this issue, and go to endocrinologist, check not just sugar level, glucose level of blood, but and glycoside hemoglobin, but and amylase. It's predictors of level of amylase, predictors of pancreatitis as well. Interesting things that drug-induced pancreatitis has clinical pictures as acute pancreatitis, and we see that epidemiology of drug-induced pancreatitis from open sources represents up to 5% of all acute pancreatitis cases. Hence, it can be considered as the third common cause of acute pancreatitis after alcohol and gallstones are ruled out. The worldwide incidence of drug-induced pancreatitis is spanning around 580 per 100,000 adults, Drug-induced pancreatitis is reported to be high in patients with inflammatory bowel disease, also in children, geriatric population, and with immunosuppression. Currently, more than 500 drugs have been reported with World Health Organization database as offenders of acute pancreatitis. When I analyzed potential mechanisms for drug-induced acute pancreatitis, I can note main mechanism. It includes pancreatic duct constriction, cytotoxic and metabolic effects, included mitochondrial disorder and mitochondrial toxicity as well, accumulation of toxic metabolite or intermediary, hypertensivity reactions, negative effects of drugs such as hypertriglyceridemia and chronic hypercalcemia are also mechanisms for drug-induced acute pancreatitis, and these effects are risk factors for acute pancreatitis as well. Other possible mechanisms of action are localized angioedema effect in the pancreas and arterial thrombosis. And you see a summarized schema. Mechanism drug-induced pancreatitis is divided like we talk above. Duct obstruction. Obstruction leads to intestinal edema, which causes impaired blood flow and ischemia. Drug-induced gallstone, sphincter of Oddi, dysfunction of pancreatic duct constriction. Acidic cell injury can be happen as one of main mechanisms pathophysiology of pancreatitis. It includes release of intracellular proenzymes and lysosomal hydrolysis, which activates the intra or extracellular enzymes, toxins mediated and vascular. Defective intracellular transport. It includes cause of intracellular activation of enzymes, mitochondrial toxicity, metabolic injury, and immune-mediated mechanism as well. And all of these pathological mechanisms go and can be resulted of activated pancreatic enzymes with acinar cells producing autodigestion of pancreas and surrounding tissues, and it will be presented clinic of acute pancreatitis as well. Main etiologic mechanism proposes of drug-induced pancreatitis caused by antimicrobials and antivirals. It's a group of drugs can be cause of drug-induced pancreatitis too. It's supratherapeutic bile concentration for drug metabolites. For example, its mechanism proposed for tetracyclines. Main etiopathogenetic mechanism proposed for drug-induced pancreatitis caused by antimicrobials and antivirals. Oxidative damage, for example, its proposed mechanism for metronidazole. Mitochondrial toxicity caused by nuclear reverse transcriptase inhibitors. Hypertriglyceridemia induced damage caused by antiviral protease inhibitors. and idiosyncratic delayed immunologic of T-cell mediated response, main mechanism proposed for most of the drugs discussed of drug-induced pancreatitis. It's because pathophysiology central cause appears to be activation of digestive zymogens in the pancreatic acinar cells and subsequent autodigestion of pancreas. Number of factors can include two endotoxins, toxins, ischemia, infection, anoxia, trigger activation of proenzymes 2. And I have divided it using open sources, mechanism of drug-induced pancreatitis. One of them, and first of them is structural disorder. The structural damage such as compression, obstruction, or inflammation of the pancreatic duct may lead to acute pancreatitis. The most common cause of obstruction is cholelithiasis or gallstones. Obstruction can also be caused by duodenal inflammation in Crohn's disease. Medication with risks of gallstones is ceftriaxone, a third-generation cephalosporin that is excreted from bile duct, has been associated with the development of sludge of stones or stones in the gallbladders for some patients treated with this medication. Secondary pancreatitis has been considered in association with ceftriaxone-induced pseudolithiasis. Unlike ceftriaxone, the kidney pathway is a major means of elimination for most of cephalosporins. It could potentially explain why drug-induced pancreatitis has not been reported as class-wide induced disease. Based on increased amount of cholesterol secreted in bile, caused an increased risk of gallstones, which may explain the mechanism of 3-hydroxy-3-methyl-glutaryl coenzyme A reductase inhibitor induced acute pancreatitis. Long-term administration of dipyridamole and octreotide can form insoluble substances that precipitate in the gallbladder bile to promote gallstone formation as they are highly excreted from the bile. Another the cause sphincters of body medication can cause, and this sphincter order dysfunction can cause acute pancreatitis. Sphincters of Oddi refers of two possible conditions: papillary stenosis, edema or hypertrophy, and dyskinesia can cause of tachycardia, induced spasm that lead to partial or complete obstruction. The pancreas duct resulted in pancreatitis. Medication such as octreotide, opioids, opium, and codeine reportedly induce acute pancreatitis in association with sphincter of Oddi dysfunction. Erythromycin can cause drug-induced pancreatitis due to its prokinetic effect of the smooth muscle of the gastrointestinal tract and the gallbladder, subsequently increasing the pressure of sphincter Oddi. As an example, erythromycin and and azithromycin, its macrolides group of antibiotics, have been reported to be associated with acute pancreatitis as well. The probable mechanism of aspirin or non-steroid and anti-inflammatory drugs induced pancreatitis is due to inhibition of prostaglandins that otherwise may cause pancreatic duct constriction. Membrane stabilization of pancreatic cells may be mechanism behind the cytoprotection conferred by prostaglandins. In non-steroidal anti-inflammatory drugs associated acute pancreatitis, Sulindac seems to stand out as the individual drug from the class with the highest number of published cases as well. Mechanism of drug-inducing pancreatitis toxins. These pathophysiological mechanisms include cumulative, for example, dose-dependent effect of toxic metabolites is also hypothesized in drugs showing a consistent long latency, more than 30 days at the onset of the first episode of drug inducers such as valproic acid. When we're talking about valproic acid, you should remember taking into account teratogenic effect, and it is now a big problem for pregnant ladies who have been administered these drugs because newborn children can have problems with malformation and other teratogenic effect too. You should remember it too when we're talking about valproic acid. And when we're talking about importance of drug safety, I think that, and I all time make accentuate and attract attention on this point, that this knowledge is very important for healthcare professionals, for medical doctors, plus pharmacists. And what I see right now too is that we should build bridge between pharmaceutical industry and medical doctors, healthcare professionals, pharmacists, and provide this knowledge for medical doctors, because pharmaceutical industry, because pharmacovigilance, precisely pharmacovigilance, now is carry out knowledge drug safety, because pharmacovigilance specialists, pharmacovigilance physicians, pharmacovigilance scientists, medical writing and pharmacovigilance field write and generate documents of pharmacovigilance, and we know this we have this knowledge. If we're ready to share this knowledge with medical healthcare profession, and how to do it, it's because of webinars, of education, it's because of postgraduate education for medical doctors as healthcare profession. It's why I, with a group of professors, we decided to write drug safety in clinical practice. It's not just in therapy, internal disease. It will include all medicine, plus another one for medical doctors and healthcare professional pharmacists who already ready to get this knowledge and to get new profession. And An interesting point is pharmacovigilance in clinical trials stage, in non-clinical trial stage, because, for example, when we're talking about thalidomide tragedy, that you should remember that this investigation of thalidomide included non-clinical trials, but just in one model. It was mice, it was rats, but just teratogenic effect were reflected in rabbits. It's why very important to choose right model for non-clinical trials too. Interesting point, this knowledge is important now for pharmacovigilance specialists too. We can talk about it a long time. That's why I will be very thankful for your questions, because this topic very deep. When we now come back to our topic concerning on pharmacovigilance, exactly mechanism drug-inducing pancreatitis toxin, we can see that nucleoside reverse transcriptase inhibitor, the leading hypothesis of this group of nucleoside reverse transcriptase inhibitor associated pancreatitis, involve mitochondrial toxicity caused by the inhibition of human mitochondrial DNA polymerase gamma. The inhibition leads to impaired oxidative phosphorylation and failure to synthesize ATP, which is vital for energy requiring reaction with the cell. Tissues with this higher and highest energy demand appear to be most susceptible. Mitochondrial toxicity is shared among nucleoside analogies, and acute pancreatitis attributed to this agent has been described. The degree of mitochondrial impairment as a resultant tissue-specific clinical manifestation vary dependent of nucleoside reverse transcriptase inhibitors. Among non-nucleoside reverse transcriptase inhibitors, for example, nevirapine is associated with pancreas-related toxicitis, whereas efavirenz is not. Metronidazole, one speculative mechanism, it's another group drugs which characterize same mechanism drug-induced acute pancreatitis toxins. Metronidazole, one speculative mechanism of metronidazole-inducing pancreatitis is that under aerobic condition it may undergo redox cycling and yield hydrogen peroxide, superoxide, and other free radicals, which can be toxic to pancreatic beta cells and induce pancreatitis. These redox active compounds are toxic to pancreatic beta cells. Oxygen-free radicals have been associated with the initiation of pancreatitis. Pentamidine. Pentamidine has the toxic effect of pancreatic beta cells easily and can cause hypoglycemia or hyperglycemia. Same effects can be expected on acinar pancreatic cells. L-asparaginase. Animal models suggested that L-asparaginase induced pancreatic injury can involve disruption of plasma amino acid balance. Disruption of protein synthesis in acinar cells can cause inhibition of exocytosis following the histologic morphologic changes. Tetracycline. Medication is the tetracycline class, including tetracycline, minocycline, oxytetracycline are also associated with acute pancreatitis. Tetracycline-induced fatty metamorphosis of the liver usually accompanies evidence of pancreatitis, but pancreatitis without evidence of liver disease has also been observed after administration of tetracycline. Steinberg hypothesized that accumulation of an indefinite toxic metabolite may be the cause of tetracycline-inducing pancreatitis. Others suggest this higher biliary concentration of tetracycline may be associated with tetracycline-induced pancreatitis. Bile concentration of minocycline after a 200 mg loading dose following by one single 100 mg dose were observed to be more than 10 times higher than concurrent serum concentration, mean serum concentration of 65 mg on milliliter, range 1.85 microgram milliliter. Tigecycline is the first available member of the glycycline group, is a derivative of minocycline and can share similar side effects. Concentration of tigecycline in bile median 75.2 mg per liter, range 15.9 1150 mg per liter were also found to be several logs greater than concurrent serum concentration, median 112 mg per liter, range 1.45-1.25 mg per liter. After in single 100 mg dose. The mean and median bile to serum 24 hours area under the concentration time curve, AUCO 24 rates were 537 and 368 respectively. It is reasonable to suspect drug-induced pancreatitis as a possible complication in tigecycline-treated patients. Several causes have been reported previously. Mechanism includes the hypothesis of toxic effect on pancreas cells membrane, as the case, for example, valproate, of the formation of edema in pancreatic ducts, which may occur with angiotensin-converted enzyme inhibitors via kallikrein-kinin pathway. Some drug therapies have been associated with the occurrence of hypertriglyceridemia pancreatitis. According to some studies, more antiviral protease inhibitors are associated with a significant increase in plasma triglyceride concentration. Particularly, hypertriglyceridemia is observed more frequently after combination therapy with ritonavir or lopinavir, ritonavir than with other PI-based concentration or combination. As described below, ritonavir and lopinavir-ritonavir-based regimens have been associated with increased risk of hyperlipidemic pancreatitis. Mitochondrial toxicity mechanism of drug-induced pancreatitis. Another possible causative mechanism is mitochondrial toxicity. This appears to be associated with the use of antiviral drugs such as nuclear reverse transcriptase inhibitors to treat human immunodeficiency virus (HIV) infections. The toxicity appears to be due to the inhibition of mitochondrial DNA replication by suppression of the activity of enzymes involved in mitochondrial DNA replication. Also, acute pancreatitis is a well-described complication of HIV infection. An increased incidence of this condition has been reported after the introduction of reverse transcriptase inhibitors in HIV patients. Mechanism of drug-induced pancreatitis metabolic. The levels of triglyceride greater than 1000 milligram on deciliter may increase this risk of precipitated in episode of pancreatitis. The breakdown products of triglycerides are probably responsible for induced pancreatitis. When lipase, its enzymes in pancreatic capillary bed acts the higher level of triglyceride in serum, toxic free fatty acids are generated. Drugs included estrogens, isotretinoin, propofol, retinoid derivatives, HIV protease inhibitors, beta blockers, thiazides, and furosemide are thought to induce acute pancreatitis owing to hypertriglyceridemia. Estrogen. It's interesting topic 2 concerning estrogen and relation to drug-induced pancreatitis. Estrogen is the most well-studied drug in this manner. Exogenous estrogens increase serum triglycerides, serum and fatty acid primarily by reducing levels of lipoprotein and hepatic lipases, with subsequently decreased clearance and aggravate insulin resistance. Obese patients with underlying glucose intolerance or fasting hypertriglyceridemia are at greater risk. I want to make you how explain, pay you attention on it, because this relation estrogen hyperlipidemia because of disorder of hepatic function and its cause and decreased clearance and aggravate insulin resistance. It means that patient with metabolic disorder, with metabolic syndrome, can be in a higher group of risk of development this acute drug-induced pancreatitis. And interesting question, because for example like drugs like Diana 35, it's contraceptives. From one side, another side, it's treated disorders in women with problems with many problems. It's including a metabolic disorder and problem with hormonal status, higher in this group of women, higher level of testosterone in many cases. But from another side, Diana 35 has very severe adverse reaction. It's liver cancer, it's thromboembolia, plus you see that it can be cause of drug-induced pancreatitis from other sides, but from this group characterizes problems with hyperinsulinemia and insulin resistance, and it's very connected with development pancreatitis. You see that this cycle can be connected very strictly. It's why obese patients with underlying glucose intolerance or fasting hypertriglyceridemia are at greater risk. However, reports have also shown that estrogen-associated drug-induced acute pancreatitis can happen without elevated serum lipid concentration. It's because strict relation with hyperinsulinemia and influence on pancreas as well. It is so that arterial thrombosis may another functional mechanism of action. You remember there's one is important adverse reaction of estrogen containing drugs, medication. It's exactly thrombosis, and thromboembolia can even happen. It can cause of lethal cases too. Tamoxifen and clomifen are synthetic estrogen analogs with mixed agonist-antagonist action. Cases of tamoxifen or clomifen associated acute pancreatitis have been reported with mechanisms similar to that of estrogen. It means that it can be class-specific effects. Diazepam derived atypical psychotics, clozapine, olanzapine, and quetiapine may also be potential cause of drug-induced acute pancreatitis. Both risperidone and ziprasidone are non-benzodiazepine atypical antipsychotics and appear to have minimal effects on serum lipids. This is another example where clinicians can apply the general knowledge of each medication when evaluating the likelihood of drug-induced acute pancreatitis for the new medication. Hypercalcemia as one of mechanism of development drug-induced pancreatitis. Calcium is identified as the most important intracellular element and arsenal cell stimulus secretion coupling. Disruption in the secretory process causes the mechanism by which hypercalcemia induces pancreatitis. Based on experimental studies, increase in intracellular calcium leads to a functional secretory block with the dose-dependent characteristics. Arsenal cell stimulation induces spikes in cytosolic calcium concentration by repeatedly releasing calcium from intracellular stores, which activates the normal secretory process or digestive enzymes from intracellular zymogen stores. Excessive intracellular calcium concentration leads to sustained increases of cytosolic calcium. It results in vacuole formation and trypsinogen activation and eventually leads to edematosis and necrotitis pancreatitis. Research indicated that hypercalcemia is associated with increase in serum enzymes. Intravenous calcium administration has been associated with pancreatitis in at least 2 published reports. Additionally, pancreatitis had been correlated to cases of vitamin D poisoning and to patients receiving total parenteral nutrition. It is suspected that all drugs which can cause hypercalcemia carry risk of inducing drug-induced pancreatitis. Vascular mechanism is one of important mechanism of development drug-induced pancreatitis too. Vascular ischemia is an uncommon cause of acute pancreatitis. Pancreatic infarcts may occur in patients with underlying atherosclerotic vascular disease, but they are unusual because the pancreas richly perfused from several different arterial sources. Cholesterol emboly may cause pancreatitis, cholecystitis, or bowel ulceration of infarct or even infarction, and should be suspected when acute pancreatitis occurs after vascular intervention such as cardiac catheterization. Patients may have associated evidence of renal, good, or peripheral cholesterol emboly. Ischemic pancreatic and hepatic injury may associate with malignant hypertension, low flow states due to severe heart failure, or administration of potent vasoconstriction. Vasculitis may cause pancreatitis associated with systemic autoimmune diseases. Acute pancreatitis secondary to drug-induced lupus syndrome has also described. Contrast-induced pancreatitis may be related to decreased oxygenation and impaired circulation of the pancreas. For example, ipamidol has viscosity of 9.4 cP at 37 degrees centigrade versus human plasma of 1.72 cP at hematocrit of 43%. A similar pathophysiologic process has been proposed in contrast-induced kidney injury. Cholesterol crystal embolization may be another mechanism that results in occlusion of small arterial tube. Immune medication reaction as one of mechanism drug-induced pancreatitis. Immune-mediated reaction can be include direct immunological effect are usually observed with the first month of drug exposure, where toxic effects are noted after a few months of treatment. Researchers have also considered acute pancreatitis and immune-mediated reaction if relapse occurs rapidly after a challenge, as seen as, for example, sulfonamides and aminosalicylates. For example, it can be sulfalazine or mesalazine. The latency between the initiation of drugs and the onset of drug-induced pancreatitis is usually 1 week to a month, but re-exposure can lead to a new episode in 1 of 3 days. Cases of, for example, azathioprine or triptorelin-based mercaptan-induced pancreatitis are well documented. Studies have shown patients with decreased levels of triptorelin metabolized enzymes inosine 3-phosphate pyrophosphatase may be at increased risk of developing triptorelin-induced acute pancreatitis. However, 6-thioguanine-induced pancreatitis is less common than conventional triptorelin. Only 1% of inflammatory bowel disease patients previously intolerant to the conventional triptorelin are reported to have 6-guanine-induced acute pancreatitis after treatment. A strong correlation with immune disorders, mainly Crohn's disease and HIV infection, implies on immune medication reaction as a chief causative factor of this disease. Ransom criteria of pancreatitis I hope you know, but I won't make you pay your attention because, for example, it's important to diagnose acute pancreatitis, but question is what kind of this acute pancreatitis pathological mechanism. At admission, it can be age more than 55 years, VBC 16,000 cell in cubic millimeters. Blood glucose more than 200 milligram per deciliter. Serum aspartate aminotransferase more than 250 EU per liter, and serum lactate dehydrogenase it's more than 350 EU per liter. With 45 hours you can find serum calcium less 8 milligram per deciliter, hematocrit drop more than 10%, partial oxygen concentrations less 60 milligram hemoglobin, BUN increase more than 5 milligram per deciliter, base deficit more than 4 milliequivalent per liter, and fluid sequestration more than 6 per liter too. Commonly used drugs causing drug-induced pancreatitis and their proposed mechanism of action. There is several classifications we will talk about later, and one of these classification is Badalov classification. It's divided on classes, and when we're talking about drug proposed mechanism of action, Badalov class causing acute pancreatitis, it's divided on mechanism too. For example, angiotensin converted enzyme inhibitors include proposed mechanism of action. It's local angioedema of pancreatitis duct due to degradation of bradykinin. It's class 1A, 3, and 4. Statins include direct toxic effect of the pancreas, accumulation of toxic metabolites, secondary rhabdomyolysis, and immune-mediated inflammatory response. It's according Badalov classification class 1A, 1B, 3, and 4. Anti-HIV drugs, HIV infection itself, direct inflammation of pancreas, and secondary of metabolic disturbance. These drugs of lamivudine, nelminafir class 1B protease inhibitor, insulin resistant, can be 2. Diagnosan class 3 hyperglycemia, hypercholesterolemia, ritonavir class 4 hyperglyceridemia. Oral contraceptives induced hypertriglyceridemia risk factors or hypercoagulable state leading. You remember that it's related with hyperinsulinemia and increase insulin resistant. Class 1A2 to pancreatic necrosis can lead. Azathioprine and 6-methoxypyrin allergic or idiosyncratic class 1B. Anti-diabetic drugs, metformin, proposed mechanism of action, drug overdose, drug accumulation, acute renal failure triggered by vomiting class 3. Mesalamine, hypertensivity reaction class 1A, 1B. Metronidazole, free radical production, immune-mediated inflammation response, metabolic effects, concomitant use with other drugs using in high pylori infection. Class 1A. Tetracycline, secondary to drug-induced fatty degeneration, class 1A. Valproic acid, direct toxic effect of free radicals on the pancreatic tissue, depletion of superoxide dismutase catalase glutathione peroxidase, class A. Idiosyncratic reaction, Diuretics, loop diuretics, erythrochlorothiazide, direct toxic effect to pancreas. Diuretic induced stimulation of pancreatic secretion and ischemia, and hydrochlorothiazide induced hypercalcemia and hyperlipidemia. It's class 3, 2 and 4. I want pay your attention to Propofol 2 because when I analyze it open issues articles, I can say that Propofol in majority cases can lead to acute pancreatitis when patient has pancreatopathy, and it's this patient can even does not know about it, and it can be problem because Propofol, we know about syndrome infusion of Propofol. It's in long administration, long surgery, plus in higher doses can be very dangerous to a patient as syndrome infusion of Propofol. But dangerous effect is realized when a patient has pancreatopathy. What kind of pancreatopathy is interesting question because it's now it's not detected, for example, majority cases before surgery. Propofol introduced itself to the market about 3 decades ago as safe as short-acting anesthetic agent. Its use is extended a long-term hypnotic and sedative infusion in critical ill patient. It's a very effective drug and it's safe drug, but this factor risks, we know that there is a risk and this factor risk, and risk can realize not in every case, but when, for example, influence and factor risk too. And significant weight of publication case reports mention a causal relationship between Propofol and acute pancreatitis, but I pay attention now majority of authors attract attention and note that this group of patients has specific pancreatopathy. A recent systematic review specified the Propofol pancreatitis relation as a probable. According to Badalov et al. Classification system, Propofol is a class 1A drug, acute pancreatitis documented along with positive drug rechallenge. Propofol is suspended in a lipid emulsion that can be factored in Propofol-related hypertriglyceridemia in susceptible people. Propofol-related pancreatitis has been attributed to developed hypertriglyceridemia, a traditional etiology for acute pancreatitis. Hypertriglyceridemia more than 1,000 mg per deciliter was documented at time of acute pancreatitis in reports of Propofol pancreatitis. However, in other Propofol pancreatitis was documented is in absence of hypertriglyceridemia. Acute pancreatitis inferred to Propofol could have many mechanisms. Intensive care unit patients and prolonged high-rate Propofol administration are considered risk factor of Propofol pancreatitis as well too. Accordingly, monitoring serum triglycerides, amylase and lipase is advisable in case of prolonged Propofol administration. Because it's very dangerous, for example, in patients with pancreatitis. It should be diagnosed, but for example, intensive care unit with acute condition, sometimes no time for some procedure, but when you would like and you see that it's necessary to administer Propofol, you should make to detect amylase and lipase, monitoring serum triglycerides, amylase and lipase. Acute pancreatitis should be suspected in any patient developing abdominal pain after propofol infusion, and the drug should be discontinued in this area of propofol-associated acute pancreatitis is considered as an statin. Angiotensin-converting enzyme inhibitors, a possible mechanism. We talked about this group, but I won't make accent on this because arterial hypertension now highest spreading disease in population, and you should understand that bradykinin system can cause not just acute pancreatitis but COX, and in many cases I met situations that pulmonologists treat chronic bronchitis in the group patient, but this just adverse events of angiotensin-converting enzyme inhibitors. So what you should do, you just change, for example, this group to another group, and this patient will feel better, and quality of life will get increased. A possible mechanism of action for angiotensin-converted enzyme inhibitor-induced acute pancreatitis is proposed to follow the mechanism of local angioedema of the pancreatic duct. Angiotensin-converting enzyme inhibitor decrease the degradation of bradykinin, that linking of the development of angioedema. Pancreatitis associated with angiotensin-converted enzyme inhibitors is thought to reflect localized angioedema of the gland, linked probably to increased bradykinin secondary to its decreased degradation. Angiotensin II receptors regulate pancreatic secretion and microcirculation, and this effect may contribute to the pathogenesis of angiotensin-converted enzyme inhibitors, inducing pancreatitis. However, angiotensin-converted enzyme inhibitors, in particular captopril, showed an important role in attending vascular permeability in experimental severe acute pancreatitis in rats, reducing expression of matrix metalloproteinase 2. No human studies are available yet to confirm this experimental evidence and to develop a target therapy. In summary, there are controversies of the role of angiotensin-converted enzyme inhibitors in drug-induced pancreatitis, since they may induce mild pancreatitis in humans but may reduce the severity of experimental and acute pancreatitis in animals. Demonstrations show that bradykinins are released during acute pancreatitis when in concordance with observed increased vascular permeability in the pancreas during acute pancreatitis. This release can result in pancreatic edema, causing enzymes and other toxic substances to be trapped within the pancreas and leading to tissue damage in the pancreas and acute pancreatitis. In addition, angiotensin II receptors may be important in regulating secretion and microcirculation with the pancreas too. Statins. The onset of acute pancreatitis induced by statins has been observed from hours to years after treatment. Because of the variance of the latency period, the mechanism may be related to direct toxic effect to the pancreas and the accumulation of toxic metabolite. Other mechanisms of action of statin-induced acute pancreatitis are speculated to be associated with rhabdomyolysis, myalgia, and or metabolism or drug interactions through cytochrome P450, 384, this type of cytochrome. In several cases, reports either myalgia or rhabdomyolysis occurred before development of acute pancreatitis. Because pravastatin does not metabolize cytochrome P450 A4, it may have favored cases report of drug-induced acute pancreatitis than other statins. Oral contraceptive hormone replacement therapy. Both of the proposed mechanisms for acute pancreatitis caused by estrogen are related to the negative effect of oral contraceptives and hormone replacement therapy. The first proposed mechanism, the patient is developing hypertriglyceridemia as a new diagnosis. Existing hypertriglyceridemia is exacerbated. Patient are diagnosed with previously unknown familiar hyperlipidemia. The second proposed mechanism is in pancreatic necrosis, is induced by hypercoagulable state. Diuretic. Suggested mechanism of action of furosemide-induced acute pancreatitis induced a direct toxic effect of the pancreas. Diuretic induces stimulation of pancreatic secretion and ischemia. An experimental study demonstrates the decreased volume of extracellular fluorine lessens pancreatic blood flow, thereby leading to ischemia. Two of the negative effects of hydrochlorothiazide are hypercalcemia and hyperlipidemia. Because hydrochlorothiazide causes increased calcium resorption from the bone and increased levels of serum calcium, hydrochlorothiazides create an increased risk for acute pancreatitis. Hydrochlorothiazides also may be involved in the development of hyperparathyroidism that can lead to hypercalcemia and acute pancreatitis. Finally, hydrochlorothiazides can increase serum triglyceride levels, putting a patient at increased risk for acute pancreatitis. Highly active antiretroviral therapy infection is proposed mechanism for acute pancreatitis directly causes inflammation of the pancreas. Highly active antiretroviral therapy may also be involved in the development of acute pancreatitis because the antiretroviral therapy could potentially cause a toxic effect directly to the pancreas or induce negative effects associated with acute pancreatitis. Protease inhibitors can cause metabolic disturbance, including development of insulin resistance, hyperglycemia, hypercholesterolemia, and hypertriglyceridemia. However, triglyceride levels need to be elevated, as cases has been reported in which levels were normal. According to several studies, no significant increase of acute pancreatitis risk occurs after the introduction of protease inhibitors to treatment. Valproic acid. The proposed mechanism of action of valproic acid induced acute pancreatitis is direct toxic effect of free radicals of pancreatic tissue and depletion of superoxide dismutase catalase and glutathione peroxidase. Valproic acid induced acute pancreatitis can result from individual distinct reaction to a drug against the norm of adverse effects associated with the drug. This risk increases in patients with a history of drug sensitivity. Hypoglycemic agents. Various oral hypoglycemic agents used in the treatment of diabetes are linked to acute pancreatitis. While some association exists between the occurrence of pancreatitis and biguanide agents such as metformin, as well as with dipeptidyl peptidase 4 inhibitors including sitagliptin, vildagliptin, and saxagliptin, current research suggests that only oral hypoglycemic agents with a disproportionately increased risk of pancreatitis are the glucagon-like peptide mimetics. Of particular concern is exenatide that was linked to 34 post-marketing reports of acute pancreatitis soon after its introduction. First Sanjari has estimated on the 6-fold increase in the risk of pancreatitis with the use of exenatide compared to other therapies. The pathogenesis of glucagon-like peptide 1 mimetics analog-induced pancreatitis is unclear, but current evidence suggests an additive or synergetic exacerbation of pancreatitis when glucagon-like peptide 1 mimetics analogs are used in the presence of a higher fat diet. The sequence of injury appears to begin with acinar cell hypertrophy, progress of pro-inflammatory cytokine induction, and culminate in pancreatic vascular injury. Acid suppression drugs. In many cases, report cimetidine and ranitidine have been associated with acute pancreatitis. Of note, acid suppression drugs can be prescribed for prodrome of acute pancreatitis. It was determined that hypergastrenemia induced by continuous use of proton pump inhibitors can stimulate pancreatic enzyme secretion, eventually resulted in pancreatitis. The literature contains several case reports of omeprazole, pantoprazole, and lansoprazole-induced pancreatitis. In more than one report, the pancreatitis was severe and necrotized. In rats, intraperitoneal infusion of omeprazole resulted in pancreatic inflammation and elevated pancreatic enzymes. According to Badala classification, proton pump inhibitors are specific as class 1 drugs based on positive rate challenge with the drug and consistent latence. Anti-cancer therapies. Anti-cancer drugs almost carry the risk of precipitation acute pancreatitis. Many of the older recently proven anti-cancer therapies have been listed to cause pancreatitis. From the older agents, asparaginase used for the treatment of acute lymphoblastic leukemia is the most frequently chemotherapeutic agent causing pancreatitis. Asparaginase-related pancreatitis has been reported as an incidence of 2 to 16%. Asparaginase pancreatitis is severe in up to 15% of patients and positive rechallenge in reporting in up of 60 of causes. Isplatin and oxaliplatin are listed as inducing pancreatitis. A discontinuation of these drugs has showed regression of symptoms and laboratory evidence of pancreatitis. Everolimus and tamoxifen, everolimus and tamoxifen caused elevated serum triglycerides and hypertriglyceridemia can be the underlying mechanism of reported causes of everolimus and tamoxifen pancreatitis. In many case reports, in small cause reported to cause acute pancreatitis as well. The proposed mechanism of pancreatitis are immune mediation, direct toxicity, or hypertriglyceridemia. In concern to immune check inhibitors, nivolumab and pembrolizumab related pancreatitis have been recently reported 1.8% of patients. Also, ipilimumab, approved for treatment of melanoma, is reported to associated with pancreatitis in less than 1% of cases. Pancreatitis attributed to checkpoint inhibitors is considered as immune toxicities, and in all cases corticosteroids were the therapeutic option. The older tyrosine kinase inhibitors as sorafenib, sunitinib, and imatinib are reported to cause pancreatitis. Recent cases report have linked the newer tyrosine kinase inhibitors, vemurafenib, ponatinib, to pancreatitis, a just elevated pancreatic enzyme. The famous proteasome inhibitor bortezomib has been rapidly reported to cause pancreatitis. Non-selective transarterial hemaembolization may lead to elevated amyloids in up to 40 of cases, while TACA-related pancreatitis can happen in up to 4 cases. The larger the area infused with the hemotherapeutic agent, the greater the risk of pancreatitis. Post-TACA necrotized pancreatitis is thought to be ischemic in nature, secondary to embolic blocking of pancreatic blood supply. The new direct-acting antiviral therapies of hepatitis, drug-induced pancreatitis occurrence with a previously known combination of interferon and ribavirin had been substantiated. Nevertheless, determination whether it is interferon or ribavirin-related effect is yet uncovered, as all reported causes were combination therapy. As both drugs are immune interferon, drug-induced pancreatitis may have been expected consequences. Recently, the higher safety profile associated DAS has defined any linkage with drug-induced pancreatitis occurrence. However, bisaprevir and tenofovir were mentioned in such a fatal condition in 2 separate reports. Conversely, later generation of DAAs has been mentioned to cause drug-induced pancreatitis only in cases with ribavirin included regimes. A 75-year-old man presented with acute pancreatitis while on 3 weeks ombitosavir, paritaprevir, ritonavir, and dacarbazine, and ribavirin 1,200 mg daily, and shift to legisopsevir sofosbuvir regimen can improve the condition. Consequently, ribavirin was principally convicted in most cases of RCV therapeutic-induced pancreatitis. Data are still limited on the potential role and pathogenic mechanism DAS and drug-induced offenders. And the classification of drug-induced pancreatitis, Badalov updated Simon Linares. You see classes 1A, 1B, 2, 3, 4. 1A class description: at least one case report with positive rechallenge with exclusion of all other causes. IB: at least one case report with positive rechallenge following to document exclusion of other causes or other possible etiologies were available. 2 classes, at least 4 cases in the literature with consistency latency. 3 class, at least 2 cases in literature with no consistent latency among cases and no rechallenge. And 5 class, drug not 15 into the early describing classes. And when you see how divide the drugs, summary of drug-induced acute pancreatitis drugs, you see that class 1, it's a class which can cause majority cases drug-induced pancreatitis. It's alpha-methyl-dopa, azodesalcylate, benzofibrate, cannabis, carbimazole, codeine, cytosine, arabinosid, dapsone, enalapril, furosemide, isoniazid, mesalamine, metronidazole, pentamethylene, pravastatin, procanaimid, peristol, simvastatin, stibagluconate, salibac, tetracycline, valproic acid, sulfamethoxazole. Class AB, all trans retinoic acid, amiodarone, azathioprine, clomiphene, dexamethasone, isfamide, lamivudine, losartan, linesterol, meglumine, metimazole, nembifenaril, omeprazole, premimarin, sulmetazole, trimeptarin, sulmetazole. Class 2, acetaminophen, chlorothiazide, clozapine, DDI, erythromycin, estrogen, L-asparaginase, pegasparagase, propofol, tamoxifen. Class 3, alendronate, atorvastatin, carbamazepine, captopril. Interesting. Enalapril is class A, captopril is class 3. Ceftriaxone, chlorothiazide, cimetidine, clarithromycin, cyclosporin gold, hydrochlorothiazide, indomethacin, interferon ribavirin, irbesartan, isotrinione, ketorolac, lisinopril, metamazole, metformin, minamethicillin, mirtazapine, paclitaxel, and prednisolone. And class 4, it's ampicillin, androcorticotropic hormone, benzapril, betamethasone, capecitabine, cisplatin, cyclophosphamide, cycloheptadine, danazole, deoxydiazide, doxabucin, fluvastatin, lavastatin, ostreotide, penicillin, ranitidine, rifampicin, rosuvastatin, sertraline, tacrolimus, vincristine. And interesting that you see that when we're talking about class-specific groups, for example, enalapril, I talked about captopril class 1A, class 3, and you see, for example, macrolide can be in different classes too, erythromycin and clarithromycin. Interesting when we're talking about class-specific effect, but these drugs, because of classification of Badalov, located in different classes. There are still different classification, and according to Saini, it's one case is report with positive rechallenge with exclusion of other cases. Causes, at least one case report with positive rechallenge following documentation exclusion to other causes or other possible etiology available is class 1B. At least one case report humans without a positive rechallenge, other causes are ruled out, it's class C. Class 2, at least 2 cases in human reported in the literature without a positive rechallenge with a consistent latency, and other causes were not ruled out, class 2. Class 3, at least 2 cases in human report in the literature without a positive rechallenge with inconsistency, latency, and other causes were not ruled out, class 3. And class 4, drugs not 15 in the early described classes. Algorithm identify potential cause of drugs. You see that main aim is obtain patient history. It's very important. Exclude it's why you should to do healthcare professional and when we're talking about pharmaceutical industry, it should do like pharmacovigilance physician specialist medical education, because patient suspected acute pancreatitis has specific clinic symptoms: abdominal pain, jaundice, elevated serum amylase, lipase, hepatic transaminase level, and you should conduct differential diagnosis, but you should to obtain patient history, previous symptoms of episodic, history of gallstones, alcohol use, history of hyperglycemia or hypercalcemia, family history of pancreatic disease, prescription and non-prescription drug history, history of trauma in the presence of concomitant autoimmune disease, then imagination study of abdomen, ultrasound or computer tomography, laboratory tests including triglyceride, calcium and liver biochemistries. If consider an autoimmune pancreatitis, antinuclear antibody levels in serum immunoglobulins G4 levels should be obtained. Exclusion of common causes of its next stage of acute pancreatitis. It identifies the suspected drug associated with acute pancreatitis based on the previous summarized list, drug related to medication with known risk factor of acute pancreatitis, drugs with similar mechanism of inducing acute pancreatitis, and symptoms resolution following drug withdrawal, drug-induced etiology probable if drugs is a challenge due to risk benefits and recurrence drug-induced etiology. It means that we detect which drug can be cause of acute pancreatitis, and managing drug-induced acute pancreatitis is general as every type of acute pancreatitis. It's first of all to relieve abdominal pain and nausea, to provide fluid replacement therapy. Yes, it's the challenge drugs which induces acute pancreatitis. It's more important first stage. It's necessary action before managing drug-induced acute pancreatitis, must to be, not should to be. But if we're talking about treatment, it's include to relieve abdominal pain and nausea, to provide fluid replacement therapy, to correct electrolyte, glucose and lipid abnormalities, to minimize systemic complication, and to prevent pancreatic necrosis and infection. And I would like to talk about case: a young man with type 2 diabetes mellitus, hypertension, morbid obesity and hyperglycemia arrived in the emergency department with complaints of sharp abdominal pain. His rating on the visual analog scale was 10 out of 10. He also reported nausea and vomiting. His history including 3 prior bouts of pancreatitis, the most recent beyond 10 weeks early and 6-day stay in intensive care unit. The gastroenterology term diagnosed acute pancreatitis and associated duodenal inflammation, probably secondary to higher triglyceride levels. Medication or admission including insulin glargine, Lantus, Sanofi Aventis, 40 units at bedtime, losartan, Kazar, Merck, 100 mg daily, insulin, Asparta, Novolog, Novo Nordisk, 20 units of Catanzoli, 3 times mainly before meal, hemifibrazil, Pit Pfizer, 600 mg twice daily, sitagliptin, 1 Yanova Merck 100 milligram daily, and metformin Bristol Myers Glucophage 1000 milligram twice daily. In the AD, metformin and semaglutide were discontinued and hydration with 4 normal saline was administered. Pain relief was provided with morphine sulfate 2 mg CQ every 4 hours as needed. He was placed on acid by mouth and PO status and was started of heparin 5000 units CQ every 12 hours to prevent deep vein thrombosis. The patient was admitted to the surgical service and was found to have infected right foot. He received wound care and follow-up care subsequent hospital days. On the second hospital day, he still complained of pediatric pain. Full hydration was continued and PO status was maintained. On the fourth hospital day, the patient was much improved and was discharged to follow up with outpatient MRCP to evaluate the biliary and pancreatic ducts. The gastroenterology team concluded that pancreatitis was probably not a result of alcohol use. Of note, the patient had been taking sitagliptin at home, but it was discontinued on admission. The hospital staff, as attending physicians, were informed by the clinical pharmacist that sitagliptin hyperlipidemia could cause pancreatitis. The final outcome of the patient diabetes treatment was not known. And you see that what we should do, we should analyze conduct complex analysis of patient. It's why you need clinical experience, clinical thinking, clinical experience working in hospital, and knowledge, clinical knowledge of internal disease, clinical pharmacology, safety of drugs, drug safety, because you should find out what reason of these cases. Another case too, a middle-aged man with hypertension, type 2 diabetes, hyperlipidemia, anxiety, depression, obstructive sleep apnea, was admitted with dual pre-umbilical pain. His VAS rating was 8 of 10. He was receiving multiple medication including daily sitagliptin and colevesevilam, Wellhouse Onco Pharma 3.750 mg. The patient was started of ciprofloxacin, ciprobil and metronidazole fluoflagil because of abdominal pain and elevated white blood cell count in triads. Amylase and lipase levels were elevated, metformin and sitagliptin were withheld, blood glucose levels were tested, and he received slided scale regular insulin, Nova Nordisk, Humulin R, LED, and finger sticks for time daily. On second day, colevesevilam was also withheld when the staff realized it must cause pancreatitis. A surgeon recommended hydration with full fluids and PO status. Morphine was recommended for pain. No surgical intervention was warranted. On the third hospital day, the patient had only low-level pain and was rated 1 of 10. Amylase and lipase level returned to normal and his white blood count decreases. The next day, the patient was discharged. Metformin and sitagliptin but not colesevelant were restarted. The clinical pharmacist informed the attending physician and staff of the possibility of sitagliptin-inducing pancreatitis because the patient had been taking the drug at home. The patient was discharged and resumed taking sitagliptin. The final outcome was not known. and you see that still it can be cause of anti-diabetic drugs, sitagliptin in this case. And case 3, a middle-aged woman with type 2 diabetes, hypertension, chronic obstructive pulmonary disease, asthma, sleep apnea, anxiety, osteoarthritis, neuropathy, disc herniation, and morbid obesity, presented in AD with 1 week history of abdominal pain and nausea. She also had polyuria, shortness of breath, and anxiety. She had been taking sitagliptin 100 mg daily, but had stopped 4 days early because she ran out of medication. Other diabetes agents included insulin glargine 38 units in the morning and 38 units in the evening, metformin 1000 mg twice daily, and pre-meal insulin aspartate. Her home finger sticks glucose values ranging from 200-300 gram on deciliter. Her MLS level was 154 U per liter, normal 2385, and her lipids level was 485, normal 160 U per liter. The patient was admitted for hyperglycemia and pancreatitis. She received 2 doses of regular insulin 10 units and continued her home dose and regimen of insulin glargine. Has blood glucose level were tested, and she received sliding scales, regular insulin and finger sticks 4 times daily. Insulin, aspartate, metformin, and sitagliptin were withheld. Her other drugs were continued. On the second hospital day, an ultrasound showed gallstones and amylase and lipids levels showed downward trend. Glycosylate hemoglobin was 13.4 gram per deciliter. By the 3rd day, her symptoms resolved and she was discharged with scheduled follow-up appointment for the next week. My dear colleagues, my dear friends, thank you for your attention. I hope my webinars will be very usable in your practical activity, and I will be thankful if you will subscribe on my YouTube channel. It will give ability for increasing audience who need this knowledge, because I think that we understand that our main aim is safety of patients, and from my side I will do all best to create these webinars, these lectures in order to share, popularize, and create culture of safety administration of drugs, because of quality of drugs depend on the life of patient. And what I want to pay attention to, that now pharmacovigilance and drug safety carry out transdisciplinarity and multidisciplinarity character. It's why, because everybody who involved in treatment of patients, it can be a healthcare professional, medical doctors, pharmacists, who clinical pharmacologist, or pharmacovigilance physician, medical writers, QPPV, pharmacovigilance specialist from pharmaceutical industry. They have everybody of them have responsibility of safety of patient, and we should have this specific knowledge, starting from research and development, how created drugs, what influence of drugs, its majority depends on from pharmaceutical industry, and then on clinical trials, plus post-authorization period. It's come out in this process it's healthcare professional and pharmacist, and we should have this combined knowledge. It's why I will be very thankful if you will provide for me your questions you need, and again I will do all best to answer your question. And I plan it, I'm planning before, I'm planning now streams, questions and answers, and for example for every topic which you like, and I want that we talk and to find this solving of this problem, because you see that if you talking how to solve problem exactly in if emergency unit patients who have acute conditions, I think we still have many questions concerning drug safety. And please follow my updates, because parallel I think I will write a book too, and you can find it, and I will provide you links where you can find it. Thank you very much. You see my contacts, you can email me with your question, you have telephone number, you can contact me using many instruments. It can be LinkedIn, it can be Facebook, I'm present there, and I think that we will solve all questions together. Thank you very much. Have a nice day. Bye bye. Now spring, now nature is awakened, and I hope this beauty will help for us become better, become healthy, and improve our knowledge. Bye bye.